Hello, and welcome to the International Myeloma Foundation's Living Well with Myeloma webinar for this evening, entitled Harmonizing Nutrition and Novel Therapies. My name is Becky Bosley, and I serve as the Director of Support Groups for the International Myeloma Foundation. I am honored to welcome tonight Donna Catamero, Associate Director of Myeloma Research at the Mount Sinai School of Medicine in New York, accompanied by her colleague Abby Reiser, Clinical Nutrition Coordinator from the Ruttenberg Treatment Center of the Tisch Cancer Institute at Mount Sinai as well. And as always, we want to say a huge thank you to our sponsors for this evening, Johnson & Johnson, Karyopharm Therapeutics, and Regeneron. Here you go, Donna. Thank you.
And I think these are polling questions. This is what we're going to be discussing tonight. So thank you, Becky, for that great introduction. And I just want to start by welcoming everybody and looking at the novel therapies we have. We're really living in a renaissance for new treatment options for myeloma patients. In the past several years, we've had FDA approvals and new combinations of therapies. We just a few weeks ago, we have now 4 drug combinations in the newly diagnosed setting. And we have new therapies with varying novel mechanism of actions. And 2 of these therapies are CAR T therapies and bispecific antibodies. And both therapies, how they operate is they manipulate the T cell. And T cells are an immune cell, and you can think of them as our little soldiers fighting off anything that looks abnormal. So if there's an infection, it will go after infections. If there's a cancer cell, it would go after that cancer cell. So they have the ability to identify cancer cells and destroy them. But we know that cancer cells are smart and they evade the surveillance of the T cells. So now we have 2 mechanisms that we can use to help guide that T cell to the cancer cell. So in CAR T, or chimeric antigen receptor therapy, we're taking a patient's T cells and then we're genetically re-engineering them to target a receptor on the myeloma cell. So this now we're taking T cells and we're putting a little GPS on them. So they now know, and when we infuse those cells back, that cell is going to know exactly what cells to target. Now, bispecifics, on the other hand, it has a similar mechanism of action, but I'm not actually removing a patient's T cells. This is an off-the-shelf drug that it has 2 targets. So you can see here, this bispecific antibody, one arm of the antibody is going to grab onto that T cell. The other arm of the antibody is going to grab onto the myeloma cell, and it's going to bring that T cell right to the myeloma cell so that the T cell can destroy the myeloma cell. So here, it's really these novel therapies where we're using our own immune system to really identify and destroy these myeloma cells. So, we have several targets on the myeloma cell that we can go after, but I want to focus first on the CAR T therapy. So we have 2 CAR T therapies available for patients, and they both target BCMA, so this B cell maturation agent. And BCMA plays an important role in cell survival and proliferation, so it helps the cells grow and survive. What we see in myeloma cells is that this BCMA is overexpressed. So these myeloma cells are getting these signals to keep growing and surviving. So this is a good target for our therapy. So we want to attach onto this and stop that action. So ide-cel is available, and it's available for patients after having 2 prior lines of therapy. And cilta-cel is available for patients after having 1 prior line of therapy who are no longer responding to lenalidomide. So there are some adverse events or side effects that we do need to manage, because if we have a very novel therapy, there's going to be some unique side effects. So CAR T therapy is going to be managed, and typically this is going to be an inpatient setting where we're going to infuse the cells back to the patient, and then we're going to monitor them very closely for cytokine release syndrome or CRS. And this is a symptom where a patient's immune system gets a little, we're activating the T cells, which is part of the immune cell, and you have a release of these cytokines, which are immune substances, and they can cause havoc. So this is why we want to keep patients in the center, because we can manage patients quite well. And really, this is something that's reversible. So we manage patients for this cytokine release syndrome, any type of neurotoxicity, which again, is very self-limiting and manageable. And then we want to monitor for cytopenias, which are low blood counts. But then there are some delayed side effects. And really what I want to focus on with these delayed side effects, and of course, with CAR T therapy targeting BCMA, I worry about infections. So we worry about infections, and these can be late infections, not necessarily immediately after CAR T, but these could be several months after. And then something called hypogammaglobulinemia. So basically what that long word means is your healthy immunoglobulins, which again are an immune cell, they're very depleted. And so that makes patients prone to infection. So we want to manage that by giving a medicine called IVIG, and this helps supports patients while their immune system is low. So I'm focused, especially in the community and post the CAR T, about infections, especially when these therapies target BCMA, because it can cause that drop in the immune cells. Now let's look at bispecific antibodies. So we're very fortunate that we actually have had 3 recent drug approvals of bispecific antibodies. And again, this mimics a CAR T, but there's no downtime with manufacturing. We can pull this right off the shelf and get a patient started quickly. So we have, as I said, 3 agents. 2 of these agents target BCMA, so similar to the CAR T therapies. This is teclistamab and elranatamab. And then we have another bispecific that targets GPRC5D. This is talquetamab. In addition, we're currently investigating several other bispecific antibodies. So they're under investigation. And so we expect more bispecific antibodies to become available for patients. So some things you should be aware about bispecific antibodies. So because, again, it's a very similar mechanism to CAR T, we have some of the same side effects. So that cytokine release syndrome, neurotoxicity, and we'll manage it the same way we manage CAR T therapies. To mitigate this, we're going to treat patients what we call a step-up dosing. So instead of giving a patient the full dose with the first dose, the first few doses are going to be smaller doses to get the body accustomed to the new treatment. And we'll also add in some pre-medications. And again, this is to mitigate these side effects. Another thing we need to consider is, what does this bispecific target? Does it target a BCMA or a GPRC5D? BCMA, again, I'm worried about infections, and GPRC5D has some on-target, off-tumor side effects, and these can affect the skin, the nail, and has some oral toxicities. So now I'm going to hand it over to my colleague, Abby, and she can take it away and how we can manage some of these oral toxicities.
Good evening, everyone, and thank you for tuning in, and thank you to the International Myeloma Foundation and to all the sponsors for making today's Living Well webinar possible. I want to start by letting you know my objectives for today. I am going to explain the role of nutrition in supporting myeloma treatment, review dietary recommendations during treatment, and help you manage side effects of novel therapies through nutrition and over-the-counter medications and products. The first topic I'm going to discuss today is the benefits of nutrition, as well as dietary recommendations while on treatment. I want to start by addressing the reasons why nutrition is so important while on treatment. Eating well during treatment may help to maintain your energy, strength, and weight. Weight maintenance is especially important while on treatment because if you lose too much weight too quickly, the treatment often has to be reduced or held. Good nutrition also might help to boost the immune system, reduce inflammation, fight infection, and to better tolerate treatment-related side effects. Both cancer itself and its treatments can change the way you eat and the way your body tolerates certain foods and uses nutrients. Dietary recommendations often change throughout treatment based on how you feel and if you experience any side effects that affect your appetite and/or your ability to eat. If you're not experiencing any symptoms or side effects, I typically recommend that you follow general recommendations for cancer prevention and survivorship. But if you are experiencing symptoms or side effects, then I focus on nutrition recommendations for symptom management. Cancer treatments may increase your risk of infection, so I also emphasize following food safety guidelines, which I plan to address later on in this presentation. When I'm referred to patients who are feeling and eating well, I typically review the general healthy eating guidelines for cancer prevention and survivorship that have been set by the AICR, which stands for the American Institute for Cancer Research. These guidelines encourage patients to maintain a healthy body weight, eat a plant-based diet rich in whole grains, vegetables, fruits, and legumes, to choose lean animal-based and plant-based proteins, including chicken, fish, turkey, tofu, beans, nuts, and seeds, to limit intake of red meat, such as beef and pork, to less than 18 ounces per week, and to avoid processed meats, such as bacon and sausage, as much as possible. We recommend choosing low-fat and non-fat dairy over full-fat dairy, limiting processed foods that are high in fat, starches, and/or sugars, such as chips, cookies, candies, and sugary cereals. We encourage limiting sugar-sweetened beverages like juice and soda, avoiding or limiting alcohol to no more than 2 drinks per day for men and 1 drink per day for women. We recommend being physically active as tolerated, specifically to engage in moderate to vigorous activity for at least 30 minutes, 5 or more days per week. And finally, the guidelines discourage against the use of supplements for cancer prevention. Supplements do not offer the same benefits as eating whole foods. They're not regulated by the FDA, and research tends to be limited in terms of how they may interact with cancer treatment. So if you're hoping to start taking a supplement, make sure to check with your doctor before doing so. So now you are well versed on general nutrition guidelines, but is there a myeloma specific diet? At this point in time, there's limited research on dietary patterns and multiple myeloma risk, so the recommendations for myeloma are the same that we would recommend for most other cancers, which is also consistent with what is recommended for the general population. However, recent studies have found that following a plant-based diet may lower the risk of multiple myeloma and may slow the progression of MGUS to multiple myeloma. A plant-based diet may also reduce the risk of developing multiple myeloma risk factors, including obesity. More research is certainly needed, but I think it's safe to say that a plant-based diet deserves a place in the prevention and management of multiple myeloma and MGUS. Pictured here are 2 examples of what following a plant-based diet can look like. The New American Plate is a plant-based eating model created by the AICR to help reduce the risk of cancer and other chronic diseases. This model recommends filling 2/3 or more of your plate with plant-based foods and 1/3 or less of your plate with animal proteins. So now we know how to eat when you're feeling and eating well, but what if you're not feeling well? Many patients experience side effects from treatment, which makes it difficult to follow a plant-based diet. In those instances, I shift gears to symptom management and to increasing calorie and protein intake if you lose weight due to side effects. Which leads me to my next topic of symptom management while receiving novel therapies. Bispecific therapies, specifically talquetamab, can cause oral toxicities, including dysphagia, dry mouth, mucositis, thrush, and taste changes, all of which can subsequently lead to decreased appetite and weight loss. Dysphagia is the medical term for swallowing difficulties. If you're experiencing dysphagia while receiving treatment, I recommend having small, frequent meals every few hours. Blended soft and moist foods such as soups, yogurt, and mashed potatoes will typically be easier to swallow than anything hard, sticky, or dry like chips, dry tough meats, and hard raw vegetables. Liquids tend to be easier to tolerate than solids, so I often recommend including smoothies, shakes, and/or oral nutrition supplements in your diet, especially if you are losing weight. Most patients tell me meats are difficult to get down. For those who want to eat meat, I'd recommend taking very small bites and chewing them well, and then swallowing each bite with water. I'd also suggest having it with a sauce or in soup to soften the consistency. Finally, make sure you eat sitting upright to prevent choking. For dry mouth, I typically emphasize trying over-the-counter dry mouth rinses, sprays, or lozenges. The most commonly used products that I've seen are Biotin or ACT dry mouth lozenges or Biotin dry mouth spray. Sometimes these provide relief, but not always. I also recommend flossing regularly and rinsing your mouth before and after meals with plain water or a mild alcohol-free mouth rinse, such as Biotin dry mouth oral rinse, or a homemade mouth rinse that contains 3/4 teaspoon salt, 1 teaspoon baking soda, and 1 quart of water. A lot of patients with dry mouth benefit from using sugar-free gum, mints, and sugar-free candy to stimulate saliva production. Out of all of these, I find lemon drops often work best. In terms of foods, I recommend choosing softer foods that are room temperature or cold, such as blended fruits and vegetables, yogurt, very tender animal proteins, and well-thinned cereals. Smoothies and pre-made protein shakes are also good options to try. I would also suggest adding broth, soup, sauces, gravy, oils, or butter to moisten foods. Good fluid intake is especially important for dry mouth. You should aim for 8 to 10 cups of fluids per day. However, caffeinated beverages such as coffee, tea, and colas, as well as alcohol, may worsen dryness, so I recommend limiting those. Dry mouth can increase the risk of developing oral thrush, and therefore it's important to monitor for signs of thrush, glossitis, which is inflammation of the tongue, and soreness. If this occurs, we recommend starting antifungal medications right away, which Donna will discuss further in later slides. Mucositis, which is inflammation of the mouth, is a side effect that is associated with bispecific therapies. Good fluid intake and oral hygiene is important for this side effect as well, which includes brushing, flossing, and rinsing your mouth regularly. I would also suggest trying to drink liquids through a straw, which may help bypass the sore area. Similar to dysphagia and dry mouth, soft, moist, and bland foods tend to be the easiest to tolerate. Chilled foods and fluids are also good options, such as ice chips, popsicles, or frozen yogurt. Finally, I recommend avoiding hard, dry, or crunchy foods like chips or pretzels, as well as very spicy, acidic, or sugary foods and alcohol. Last, but certainly not least, is taste changes, which is medically referred to as dysgeusia. I have found that dysgeusia is to be one of the most common and one of the most difficult to manage of the side effects of bispecific therapies, specifically talquetamab. Taste changes are especially hard to manage because there's no one-size-fits-all approach. But let's start with a point that I emphasize to everyone, regardless of their experience, which is good oral hygiene. I encourage patients to try using the homemade baking soda and salt rinse throughout the day, or an alcohol-free mouthwash, as I mentioned before. Brushing the tongue and teeth after meals and before bed is also important to keep the mouth clean. And finally, it doesn't hurt to try sugar-free gums or mints to see if that improves any unpleasant tastes in the mouth. There are also a few over-the-counter products that have been made for taste changes, including Miracle Berry and Mediquel. Miracle Berry is a tablet made of miracle fruit and cornstarch, which works by binding to the sweet receptors on your tongue to make sour, bitter, and acidic foods taste sweet. Mediquel is an oral rinse that contains essential oils, including spearmint and peppermint oils, which are advertised to provide relief from metallic taste, bitterness, and other unpleasant tastes in the mouth. I've seen patients on other treatments benefit from using these, but I haven't seen many significant improvements from using these while on bispecific therapies. However, I honestly don't know of many patients who have actually used these on a consistent basis. So if you have the means to try these, I would encourage you to do so. Finally, we've also been encouraging patients to try cryotherapy or cold therapy for oral toxicity relief. The image of the woman on this slide depicts an icing neck wrap, which we encourage patients to apply for a minimum of 1 hour, 3 times a day in the first 1 to 3 weeks of treatment. Compliance with this has been challenging in both the inpatient and outpatient settings for multiple reasons. However, I do have one patient in the outpatient setting who's been icing 3 times per day, especially during the week after she receives treatment, and she feels that it has helped to improve her taste. An alternative method of cryotherapy that you might find easier is chewing on ice chips for 1 hour, 3 times a day. If you are willing and able to try either of these methods, I think it could be worth doing so to see if they help. When it comes to taste changes, I hear a wide range of statements starting with everything tastes. I included the image on the left of this slide to give you a sense of the classic flavor pairings to try based on how things taste to you. For example, if food tastes too bitter or too sour, I often recommend adding something sweet to your food, like honey or fruit. If food tastes too sweet, try adding an acid such as vinegar, lemon, or other tart, tangy, or acidic flavors. This image did not include metallic taste, so I included a few tips myself. For metallic taste, I recommend using non-metal utensils and cookware, such as plastic, glass, or ceramic, instead of metallic, trying fresh or frozen foods over canned, and serving meat cold or at room temperature. When it comes to bispecific therapies, specifically talquetamab, I think the most common everything tastes statements that I hear is everything tastes bad, has no taste, tastes like cardboard, or something to that degree. I feel like this is one of the most challenging and frustrating side effects to deal with because there's no one size fits all approach, no one miracle food that everyone enjoys, no medication that provides total relief. So it is really tough to find foods that patients can enjoy, let alone tolerate. I always emphasize the importance of experimentation. Taste is the combination of the taste, the smell, and the touch of food. So if you can't get any pleasure from taste, maybe we can shift our focus to smell or texture. I know this is probably easier said than done, but I strongly encourage experimenting with different flavors, textures, temperatures, herbs, spices, seasonings, and sauces because you never know what might work for you. One patient told me that she uses layers of flavor and texture to make foods more palatable. For example, instead of having a burger with ketchup, she better tolerates a burger with cheese, fried onions, mushrooms, lettuce, and tomato. She says that the more ingredients or layers you add, the better chance that you may have of finding some level of enjoyment or at least tolerance for the meal. I also often hear that foods flavored with acids such as lemon, lime, vinegar, and tomato tend to be more palatable. I recommend adding fresh lemon or lime juice during and after cooking, adding citrus such as lemon packets or sliced lemons and oranges to water if plain water tastes unpleasant. I also recommend sucking on sour citrus or sugar-free lemon drops, gums, or mints. In terms of texture, soft, moist foods and liquids tend to be easier to tolerate simply because they don't require as much chewing, they're easier to swallow, and therefore they aren't in the mouth as long. Smoothies and oral nutrition supplements are often a go-to recommendation of mine because they are quick and easy ways to get in calories and protein, and smoothies especially allow for experimentation. Fruit is often tolerable with dysgeusia, so I recommend experimenting with blending different fruits and smoothies to see if that makes them easier to get down. If the taste is still unpleasant despite experimentation, you may benefit from trying a straw so the taste doesn't linger in the mouth as long. Animal proteins tend to be tough for people to get down, so I recommend choosing softer animal proteins such as egg salad or fish, or marinating and cooking meat in acidic dressings or sweet juices. I could go on for days with tips that I've learned from patients regarding dysgeusia over the years, but I think the most important thing to remember, as I said before, is everyone is different, and one recommendation that works for one person may not work for the other. So keep trying and retrying foods because you never know what may end up working for you. Also, even though everyone is different, if you are experiencing these side effects, just know they are common with these treatments and you're not alone. Here are a few meal and snack ideas that my patients who are experiencing oral toxicities have tried and have been able to tolerate. I think you'll see a common theme here that a lot of these foods are soft and moist. Cream of wheat, oatmeal, and eggs are popular breakfast options. Blended soups, egg salad, fish, mashed potatoes, and pasta cooked soft in sauce or soup could also be worth trying for and with lunches and dinners. And going back to what I said about experimentation, if you can't tolerate plain oatmeal or if you're losing weight, Try adding things like milk, butter, sugar, honey, syrup, or fruit. Same goes for something like mashed potatoes. Experiment with additions like butter, gravy, or guacamole. A lot of people tell me they go for fruit, yogurt, or ice cream between meals. Smoothies and oral nutrition supplements like Ensure and Boost are often staple items, especially in the beginning of treatment when you are adjusting to new side effects. Finally, I included a few condiments, dressings, and herbs to try. Lemon, balsamic vinegar, mustard, gravy, and honey are among the most popular. However, I don't want anyone to feel bound to this list. I would strongly encourage you to experiment outside of this list because, like I said, everyone is different. These oral toxicities and treatments in general often lead to decreased appetite and weight loss. So here are a few tips in case you're struggling to eat enough to maintain your weight. I recommend consuming small, frequent meals every 2 to 3 hours and choosing nutrient-dense, high-calorie foods as tolerated. I often emphasize healthy fat sources because fat contains more calories per gram than proteins and carbs. Some good nutrient-dense foods include nuts, nut butters, avocado, and hummus. I also encourage homemade smoothies, shakes, and oral nutrition supplements because sometimes it is easier to drink your calories than eat them when appetite is low. I recommend low-impact physical activity is tolerated to help increase appetite and maintain muscle mass. Finally, if your appetite has been consistently low and you're struggling to eat, it might be worth asking your doctor if starting an appetite stimulant is appropriate for you. Now I want to shift gears to other possible side effects of novel therapies outside of oral toxicities. These include GI symptoms, specifically nausea, diarrhea, and constipation, fatigue, and infections. Starting with nausea management, we recommend shifting from 3 large meals per day to small, frequent meals because it is easier to digest and there's a better chance that you will meet your calorie needs by eating this way when nauseous. Focus on bland foods like toast, yogurt, potatoes, and rice. Avoid fatty, greasy, spicy, fibrous, and gas-producing foods. Drink fluids between meals rather than with meals. Colder room temperature foods are often easier to eat than hot foods, mainly because they emit less smells. Avoid the kitchen during cooking hours. Try ginger and ginger products. If you are prescribed an anti-nausea medication, I encourage you to take it as prescribed to see if it provides any relief. Finally, constipation can cause nausea, so managing constipation may also help to manage your nausea, which leads us to our next topic. If you are experiencing constipation, I emphasize fluid, fiber, and physical activity. Drinking hot liquids, especially caffeinated ones, can help provide relief. The temperature can speed up digestive motility, and caffeine stimulates the bowels as well. You can try prunes, warm prune juice, figs, or papaya. A high fiber diet may also be beneficial, but we recommend increasing fiber intake gradually so as not to cause more GI issues. Exercise often as feasible. And finally, talk to your team about bowel regimen medications like stool softeners and laxatives, which are often the most effective tools that we have. If you are experiencing the opposite problem, I recommend having small, frequent meals throughout the day, include foods containing soluble fiber in or with those meals, such as mashed potatoes, bananas, and applesauce. Soluble fiber is beneficial because it absorbs water in the digestive tract, which firms stools and makes them slower to pass. Good hydration with water, broth, coconut water, and or electrolyte drinks is also important. And I included a few images of brands that I often recommend on this slide. You could also try a bulking agent containing psyllium fiber such as Metamucil. And it's always worth discussing antidiarrheal medications with your doctor if you haven't been recommended one already. There also are a few foods, beverages, and additives that I recommend limiting when having diarrhea. These include sugar alcohols, which are often found in foods labeled sugar-free, fatty, greasy, and fried foods, dairy products, foods containing insoluble fiber such as raw fruit and vegetables, alcohol, and caffeine. Fatigue is one of the most common symptoms among myeloma patients and one of the most common side effects of treatment. Recommendations for management include staying active, eating often and adequately, drinking plenty of fluids, planning ahead by asking for help with meal prep, trying meal delivery services, and keeping ready-to-eat snacks on hand. Finally, stress can worsen fatigue, so if you have been feeling stressed, make sure to talk to your healthcare team about available resources for management. The last potential adverse reaction that I plan to discuss today is infections and their prevention. Cancer treatment can weaken your immune system, which can make you more susceptible to foodborne illness, otherwise known as food poisoning. This occurs when you eat food that has been contaminated by disease-causing bacteria, viruses, or parasites. Therefore, it is important to follow food safety guidelines while on treatment in an effort to reduce infection risk. General tips include washing your hands well, separating ready-to-eat food and raw meats, checking expiration dates, refrigerating leftovers immediately, and avoiding high-risk places like salad bars and buffets. Certain foods and beverages have a higher risk for bacterial contamination than others. So if you are immunocompromised, I recommend sticking to the foods on the recommended side of this chart over the not recommended side, which includes choosing well-done meat over raw, rare, and undercooked meats, and pasteurized over unpasteurized dairy products, just to name a few. As I previously mentioned, many of these side effects that I discussed today can lead to reduced food intake and weight loss. Malnutrition is very prevalent in the cancer population, and it negatively affects clinical outcomes, treatment response, and overall survival. Research has shown that early clinical nutrition interventions are associated with a reduction of therapy-related toxicity, delays in cancer treatment, and morbidity and mortality, which illustrates the pivotal role that nutrition plays with staying on treatment. So to wrap up my portion of today's webinar, if you are experiencing any of the side effects that I mentioned today or outside of today, please speak up and let your medical team know. The sooner your team is aware, the sooner they can provide supportive care or treatment to help manage those side effects. And if the side effects you experience make it difficult to eat, do not hesitate to ask for a referral to a dietitian if your team has not referred you to one already. We are always here and happy to help you in any way that we can.
Thank you, Abby. So I'm going to continue the discussion on the novel therapies. So as I said, some of the side effects that I worry about are infection prevention. So infection, especially again with those treatments that target a BCMA. So we have CAR T therapies and two of our bispecific antibodies, they target BCMA, and this puts patients at risk for infection. So I want to try to prevent these infections. Just having myeloma. So we know that patients who have myeloma are at even higher risk for infections just because of the nature of the disease. And on top of that, I'm adding treatments that even more compromise the immune system. So we have to stay very vigilant on, preventing infection and reporting signs and symptoms of an infection. So any temperature greater than 100.4, that is a phone call to your healthcare team. And I'm giving you permission to call at any hour of the day, because that can be a sign that something bad is going on, and we want to manage that immediately. So some infection prevention tips, good oral hygiene, good hygiene skin, because how does bacteria enter, through eating, through compromising of the skin, cuts, etc. We also want to, we're just getting into flu and COVID season. So we want to be aware if we're in large crowds, and be aware of, where you are. If there is an outbreak of flu or COVID, it's okay to mask up, especially in those large crowds. So if you're in a high risk environment, take precautions. Even now in New York City, plenty of people are using masks on the subway because we're starting to see spikes in COVID infections. And then, vaccinations. So again, this is the fall. So we start vaccinating people against flu and COVID. And I really highly recommend that, in addition to flu and COVID, make sure you're up to date on your pneumonia vaccines. There's RSV vaccine now for patients. It really will provide you with that protection, because these are the infections that get patients into trouble, and these often lead to hospitalizations. We saw last year, actually, that COVID led to more hospitalizations than the flu. So you really want to give yourself some protection with those vaccinations. In addition, I think almost all of my patients are on viral prophylaxis, so either a cyclovir or a valacyclovir. And again, that gives us protection against shingles. And this is in addition to the vaccine. We need that extra layer of protection. For patients on these bispecifics and on the CAR T therapy, we'll add in extra antibiotics, pneumonia prophylaxis, so PJP, pneumonia. We'll add in extra medications to help prevent that. And then if I see that a patient's IgG levels are very low, that's when I'm going to initiate intravenous IG, so IVIG, and we give that on a monthly basis. And then we'll monitor your blood counts. So if I see that your white cells are low, I might add in some growth factor support to make sure that your white cell count is at a good number to help, again, protect you against those infections. And then I do want to stress again that those therapies targeting BCMA, those patients have a higher risk of infection. So if you are on a treatment that targets BCMA, just note that you are at higher risk, and talk to your healthcare team on ways that you can prevent infection. So as Abby, we were talking about these oral toxicities. And again, these are usually associated with talquetamab, so that targets GPRC5D. So unlike BCMA, and we see these taste changes. And as Abby was saying, we don't have this silver bullet that prevents or takes away these side effects. So at our institution, what we're doing is, with the initiation of therapy, we're adding in a dexamethasone and a nystatin oral solution where patients will swish and spit. These interventions that I'm talking to you about, they're not proven yet, and we're doing several studies now to see if these interventions do provide a benefit. But anecdotally, we can say that it does help some patients. So we do start these oral solutions for patients, and again, this is to prevent. This hopefully lessens the taste changes and helps prevent the tongue swelling. For the dry mouth, we add in saliva substitutes, as Abby was saying, the biotine or the normal saline rinses for the dry mouth. Those citrus candies can be very, very helpful. And then dysphagia, and that's when I send a little email to Abby to talk to my patients about those dietary modifications. And if I see that a patient is losing weight, to me, I never want that to happen. And if we're doing our dietary interventions, we can add in an appetite stimulant if I see that the patient is not making strides in regaining some lost weight. So we can also see, so we have the oral toxicities, but when we can also see these skin toxicities in the nails and in the skin. So we can see some skin peeling of the palms of the hands, the soles of the feet. We can see generalized body rashes. And then we also see these nail changes, which are the nails become soft, brittle, ridging, and some patients even can have a complete nail loss. So prior to initiation of talquetamab, we advise our patients to start using those heavy moisturizer barrier creams to help prevent that dry skin, and continue on with those moisturizers. If I do see that patients are starting to have that peeling of the hands and the foot, I'll add in the ammonia lactate lotion. And we'll do this twice a day. And these symptoms are very self-limiting. So if a patient presents with these skin toxicities, I can intervene and they're reversible. So unlike the oral toxicities where we're managing patients throughout therapy, patients who have these skin side effects, we can manage them with these topical ointments and they will resolve. So with nail peeling, we add in some nail hardener, vitamin E oil to the cuticles. I just want to make sure that there's no infection around the cuticle, so we'll monitor that. And if there is, we can put some antibiotic ointment around those cuticles. With the nails, those nails will be brittle throughout the treatment, but once we stop the treatment, the nails will regrow. But for the duration of the treatment, patients will have those brittle nails. If the patient does develop a rash, we treat with steroids. If the rash is an itchy rash, we can add in a Claritin for a few days. And again, this will typically resolve. So we can manage, like I said, these skin toxicities quite well. But there are other side effects to the other treatments we give. So steroids, and this is usually the one drug that we have the most issues with because steroids can literally affect every body system. So, how I recommend taking steroids, we recommend taking them with food, and, steroids can change a patient's energy level. So it'll be like a roller coaster. They'll have all this energy in the middle of the night, and then the next day they crash. So sometimes we can time when we take the steroids so that maybe you'll crash during the night and not you'll be awake during the night. So talk with your team and see when the best time to dose these steroids. Stomach issues, we can add in like acid reflux medication to help prevent some of those reflux issues that we see with steroids. But these can be problematic. And if you're just not tolerating the steroids, talk to your team. We can decrease the dose of the steroids and maybe change the steroid to maybe a more tolerated medication. Pain management, myeloma patients, we have bone issues. So pain can really compromise a patient's quality of life. How we manage pain, we can, we often give opioids or medications to manage the pain, physical therapy for pain. But talk to us. I don't think patients, you don't need to be a martyr. We can help manage your pain so that you can still live, a productive, active life, that the pain is not making you sedentary. So we have a number of pain regimens that we can offer patients. Peripheral neuropathy is another side effect that patients really have trouble with. So a lot of patients who have received the proteasome inhibitors, we see a lot of neuropathies with Velcade. Thalidomide also has neuropathies, and these are like numbness, tingling in the hands and the feet. That's something you want to report immediately because we can dose reduce the Velcade if needed. We now give Velcade once a week, and that often can decrease the incidence of the neuropathy. And we can rule out other causes for neuropathy. If you have elevated sugar or your diabetes is not well controlled, sometimes once we get that under control, the neuropathy can lessen or resolve. So we want to make sure there's no vitamin deficiency with Bs. So we'll rule out other causes. And if we need to, if it is caused by the treatment, we'll reduce that. And if we need to, we will change out the drug for a better tolerated regimen. Kidney functions is very important for patients. We know that myeloma can attack the kidneys. So we want to make sure that we're really protecting the kidneys. So we're staying hydrated. We're avoiding any medications that can possibly harm the kidneys. So NSAIDs, so ibuprofen, Advil, they're great pain medications, but they're not good for the kidneys. So please do not use them for your pain. Talk to us. We can come up with, other regimens for you that will keep the kidneys safe and manage your pain appropriately. But you do want to make sure you stay well hydrated. You want to be sure you're drinking 1 to 2 liters a day. We really want to make sure we keep those kidneys well hydrated. And then, overall, the healthier you go into a regimen, the better tolerating the better you'll go in to a treatment, the better you'll tolerate our treatment. So we want to make sure that your blood pressure is under control, that you're not forgetting about your other annual screenings, checking your cholesterol, making sure, your diabetes is well managed. Don't forget your colonoscopies and your other annual screenings. Patients have that diagnosis of myeloma and they forget about everything else. So you want to make sure that you continue with your annual exams and your checkups. Again, so the better we can manage other comorbidities or other disease problems, the better that a patient can tolerate their treatment. So with that, I want to make sure that we have enough time for questions.
We do. We have a good amount of questions. So I think what we'll do is alternate between the two of you if that works the best for you. So Abby, I'll start with you first. Question number 4. Why do you recommend no supplements, especially like turmeric? The doctor doesn't like to talk about supplements either.
So I mentioned a couple of the reasons for it. And one of the main reasons is they're not regulated by the FDA. They're oftentimes adulterated and there's not a lot of research. I use 2 different sources, Sloan Herbs being one of them, to just see what the research is. But there's not a lot on humans showing how certain supplements will interact with your cancer treatment. So in the end, there's a lot we just don't know. So that's oftentimes why we're hesitant. When it comes to turmeric, I usually recommend just using the spice in cooking rather than taking the supplement. I've had pharmacists tell me that that's one of the most, in supplement form, it's often one of the most adulterated. So I'd rather you just have it as the spice in its whole form.
Fantastic. Thanks, Abby. And Donna, question 11, Jerry asked, what was the medicine that you had listed for treating a low ANC?
So a low ANC, there's several, it's just one class of drugs. So that we call them growth factors. Neupogen, Zarzio, they have generic drugs now. So depending on what your institution uses, it's usually a generic off of Neupogen, but they're all in that same class of drugs.
Great. And Abby, back to the supplements, do you recommend a multivitamin?
So if you're eating well and you're able to tolerate all food groups, you really don't need a multivitamin. If you have true deficiencies, definitely we'll recommend a vitamin. But I've been in rooms when patients ask this to the doctor, and usually a lot of times the answer will be, it's fine if you do, but you don't need to. If you do start a multivitamin, you have to make sure you read the present daily values on the back, and you really don't want it to exceed over 100%. There is such thing as too much of a good thing. You can overdose on certain vitamins, so you got to be careful when choosing one. But if you're eating well, you don't really need one.
Important information. Thank you. Donna, question 13. About vaccines. If our immune system is low while getting vaccines, will our immune system even generate antibodies?
So that's a very good question. And depending on who you talk to, whether or not they recommend vaccines with myeloma patients, I always say, even if you mount a small response, some response is better than no response. So for example, the flu vaccine, sometimes it's 80% effective. Some years it's 10% effective. I still think, even if I give you a vaccine and it's only going to provide you 10% protection, it's better than no protection. So I do think it's worth it because, again, patients get in trouble with these serious infections. It leads to hospitalization. So some protection, better than none.
Great. And Abby, have you had anyone use Enterade? Any recommendations around that medical food?
Yeah, I like Enterate a lot. I haven't seen it used with bispecific therapies as much, but my colleagues who work with the GI cancers tend to use it a lot. I have seen it with some multiple myeloma patients, and they said it helped with nausea management, and also some people said it helped to increase their appetite. I don't know if that was placebo, but I've seen a lot of good benefits. I think the issues people run into is it can be expensive, and a lot of times if you have taste changes, people don't like the taste of it. But other than that, I'm a fan of it. I recommend it for those who have access to it for sure and are experiencing GI symptoms.
Great. And this question is kind of for both of you. A patient saw the recommendation for green tea for neuropathy with Velcade, but she understood from studies that green tea can interfere with Velcade. Can you address this?
So let me jump in first. So you can have green tea. It's the capsules that they sell. So drinking green tea is fine. And if you want that extra layer of like, I'm a little nervous, then don't drink it on the days you're getting the Velcade. But green tea, the drink, is fine. They sell these capsules that you want to avoid. It's like a super dose of green tea. So you want to avoid that.
Great. And Abby, interesting question. Is sparkling water less beneficial than regular water? Does it affect bone loss? She's heard this, but not sure the source.
I like seltzer. I think it's fine to include often. I think the only times people run into issues is if you're drinking a lot of it, it can definitely contribute to tooth decay and enamel loss if you're drinking it very often. I usually say plain water is the gold standard, but if seltzer is another way to get in more low sugar fluids, I'm okay with it.
Okay, great. And Donna, can you explain the scrambler treatment for neuropathy?
Yeah, we don't do it at our institution, and I've actually been to a few support groups where patients have said they've used the scrambler. I'm not familiar with it, but I know that it has helped patients, when I've talked to patients, so I really can't speak to it.
Okay. Abby, big question asked several times. Can you discuss the use of pre and probiotics?
So as long as you're not immunocompromised and the doctor okays it, probiotics are okay. There's also, if you've recently had a bone marrow transplant, you're not eligible to have it. So there's a couple reasons why we say you can't take it. And I have found certain doctors are iffy on it. So I always like to just run it by each team to get their okay. But if you are trying to pick a probiotic, there's a couple things to look for. You want one that has over 10 billion CFUs. You want an acid resistant capsule. You want one with multiple bacterial strains. There's a couple of things that you need to look for when vetting these, because some of them are really gimmicky and they won't do much. So if you hit all of those things, that means it's a good option. And prebiotics just feed the good bacteria. So you can get that through food. Outside of supplements, though, you can get a lot of this from actual food too, like kimchi, sauerkraut, kefir, and things like that. So a lot of times I will push for more of the food sources rather than the supplement. But if the doctor okays it, then it's fine to take it as a supplement too.
And Donna, what do you recommend to your patients who complain of serious leg cramping with IMIDs and DEX?
So there's two things. I think quinine, so tonic water, often helps. If your leg cramps are happening at night, a glass of tonic water plus or minus the gin, but the tonic water with the quinine really does help. If the muscle cramps, you know, are severe, we can add in a muscle relaxer too, for patients to take. But usually the quinine can be quite helpful when taking the Pomalyst or Revlimid.
Great. And Abby, can you speak about low potassium levels with the side effect of diarrhea and what they can do to help manage that?
Yeah. So with diarrhea, you're losing a lot of fluids, including electrolytes. So we often see low potassium levels. Um, a lot of times people will have like a banana or two, and that helps. If they're trying all potassium rich foods and it's not really helping, then supplements are an option. But if you drink some of those electrolyte beverages that I showed on one of my slides, that's a good option too. Potassium's in a lot of fruits and vegetables. So I usually review all of those when this happens. And like I said, if the food interventions don't work, then there is supplementation is available too.
Thank you guys both, Abby and Donna, for your amazing answers to so many questions. We had so many amazing questions after your great presentation. Remember, if your question did not get answered today, you can contact our info line at 800-452-CURE or email them at the info line at myeloma.org. We also did have a question if the video from this webinar will be available on replay, and it will be, as well as the slides. They will be provided to you shortly after the webinar concludes, and they'll also be posted on our website. And remember, we really want to hear from you. Please do take a moment or two to complete the survey that will pop up on your screen when the webinar ends. And as always, we want to say thank you so much to our sponsors, Johnson & Johnson, Karyot Farm Therapeutics, and Regeneron. And Donna and Abby, thank you so much for such a great presentation this evening.
Thank you.
Thank you.